Bismillah ar-Rahman ar-Rahim. Assalamu alaikum. The round of today is preeclampsia in the form of a problem. How to approach a case. Let's take this clinical scenario. A female patient aged 19 years old, prima gravida, 35 weeks of pregnancy, came to obstetric emergency department complaining of headache and blurring of vision and epigastric pain. So the complaint was headache, blurring of vision and epigastric pain. On examination, blood pressure was 170 over 110, bilateral beating lower limb edema. Ultrasound showed single living fetus 33 weeks with adequate amniotic fluid and normal Doppler studies. Investigation was done in this for CBC, liver function, kidney function, and urine analysis, diagnosis and management. Let's take this topic first. The patient complaining of headache and blurring vision and epigastric pain. These are signs of severity of severe preeclampsia. Blood pressure 170 over 110. It is a severe elevation of blood pressure. Lower limb beating edema is not a sign of severity. Can happen in preeclampsia or mild preeclampsia. The patient age is 19 years old. It is young age. Young age is a predisposing factor to preeclampsia. The investigation is within normal, but urine analysis showing albumin plus 3, the second category of diagnosis of preeclampsia. So what is preeclampsia? Preeclampsia is defined as the presence of systolic blood pressure greater than or equal to 140 or diastolic blood pressure greater than or equal to 90 on two occasions at least 4 hours apart in previously normal tonsil patient, or if you measure the blood pressure and found it 160 mm mercury systolic or 110 diastolic, you can diagnose hypertension and initiate treatment. You do not need to remeasure after 4 hours. This is made to facilitate timely antihypertensive therapy. In addition to blood pressure criteria, proteinuria of greater than or equal to 0.3 gram in 24-hour urine connection, or protein creatinine ratio of 0.3, or you can only do diabetic protein. It is a qualitative test of +1 or 2 or 3. It will give you +1 or 2 or 3, +1 diagnose proteinuria. So you can diagnose proteinuria by 3 measurement, 24-hour urine collection, and see the total protein. If it is more than 0.3 gram, diagnose proteinuria, or you do albumin creatinine ratio equal or over than 0.3, diagnose proteinuria, or you can do diabetic urine analysis +1 or more, diagnose proteinuria. So hypertension and proteinuria diagnose preeclampsia. So let's talk about the classification of patient with hypertension. Patient coming to you and you measure the blood pressure and you see it elevated 140 systolic and over or equal to 90 diastolic. It can be chronic hypertension, gestational hypertension, preeclampsia with severe features, and eclampsia. Chronic hypertension, if the patient having a history of hypertension before pregnancy and she get pregnant, so she is a chronic hypertensive patient, or hypertension diagnosed during the first half of pregnancy, because preeclampsia is a disease that only happen in second half of pregnancy, because the mechanism of development is placental ischemia, or the absence of the second wave invasion of the spiral artery, causing ischemia of the placenta, releasing mediators causing hypertension. So if you measure blood pressure in the first trimester and you see it elevated, the patient is chronic hypertension. Gestational hypertension is a hypertension diagnosed in second half of pregnancy but without proteinuria. It's called gestational hypertension. If the patient develops proteinuria, it is called preeclampsia. If the patient is hypertensive and with proteinuria but with features of severity happens like elevated blood pressure over 160, presence of abnormality in investigation, I will see after the slide. And the last is eclampsia, which hypertension or preeclampsia that progress to fits. Any category can progress to the other category, like the patient can be chronic hypertension and develop proteinuria, and so it can lead to preeclampsia and preeclampsia with severe features and eclampsia. Gestational hypertension also must be followed during pregnancy by weekly urine analysis because it can produce preeclampsia and progress to severe preeclampsia and eclampsia. So close monitoring of the patient, of hypertensive patient, is very important. Preeclampsia with severe features is defined as one of following. We say that systolic blood pressure over 160, diastolic blood pressure 110, impaired hepatic function, progressive renal insufficiency, serum creatinine more than 1.1, new onset cerebral or visual disturbance, pulmonary edema, thrombocytopenia. There is a term called HELLP syndrome. HELLP syndrome is a shortage for hemolysis, elevated liver enzyme, and low platelet count. Low platelet count is defined as platelet below 100,000. This happens due to vasospasm causing hemolysis of RBCs and sequestration of the platelet causing low platelet count. This happens necrosis of the liver causing subcapsular hematoma and elevated liver enzyme. Elevated liver enzyme is defined as doubled the normal value, which between 15 to 35. What is the management of a case of preeclampsia? It is according to the severity of the preeclampsia we can manage the case. Delivery is the only cure for preeclampsia. Patients with preeclampsia without severe feature are often induced after 37 weeks gestation. Before this, the patient is usually hospitalized and monitored carefully for development of worsening preeclampsia or complication of preeclampsia. And the immature fetus is treated with expectant management with corticosteroids to accelerate lung maturity in preparation for early delivery. In patients with preeclampsia with severe features, induction of delivery should be considered after 34 weeks gestation. In these cases, the severity of the disease must be weighted against the risk of infant prematurity. In emergency settings, you have the priority to control blood pressure and seizure first. How to control acute increase in the blood pressure? Antihypertensive treatment is recommended for severe hypertension, systolic blood pressure over 160 or diastolic blood pressure over 110. The goal of antihypertensive treatment is to maintain blood pressure around 140 over 90 mm. Medication used for blood pressure control include the following: hydralazine, labetalol, nifedipine, and sodium nitrochloride, which is used in emergency hypertension refractory to other treatment. Seizure treatment and prophylaxis. The basic principle of airway breathing and circulation should be followed. You have to do ABC, airway breathing circulation. Secure this first. Then you give magnesium sulfate as a first line treatment for primary and recurrent eclamptic seizures. Treat seizure with IV magnesium sulfate. A loading dose of 4 grams is given by infusion pump, followed by infusion of 1 gram per hour maintained for 24 hours. Prophylactic treatment with magnesium sulfate is indicated for all patients with preeclampsia with severe features. Lorazepam and phenytoin is used as a second-line agent for refractory seizure. If the patient is delivered and the pregnancy is terminated, there is a postpartum management. Magnesium sulfate must be continued for 24 hours postpartum. You have to repeat the investigation to see if the patient has recovered, like liver function test and the platelet count must be documented, decreasing value prior to hospital discharge. Elevated blood pressure may be controlled with nifedipine or labetalol. Orally, you can control blood pressure orally by nifedipine or labetalol. If a patient is discharged with blood pressure medication, the assessment and the blood pressure check should be performed at least 1 week after discharge. Unless a woman has undiagnosed chronic hypertension, in most cases of hyperclampsia, the blood pressure returns to baseline by 12 weeks postpartum. Patient should carefully monitor for recurrent preeclampsia, which may develop up to 4 weeks postpartum, and for eclampsia that can occur up to 6 weeks after delivery. Thank you.